This vaccine equity video series is produced by the Public Health Alliance of Southern California. Our series elevates promising and replicable practices for equitable vaccine distribution. Practices happening both here in California and across the nation. Our video series will showcase community-informed and equity-centered practices that specifically aim to reach disproportionately impacted low-income communities and communities of color. My name is Marley Williams, and I am the Health Equity and Justice Manager here at the Public Health Alliance of Southern California.
And I'm Dana Sherrod, Birth Equity and Racial Justice Manager for the Alliance. The Public Health Alliance of Southern California is a coalition of the 10 health departments here in Southern California. Collectively, our members represent 60% of California's population. In this video, we talk with Christina Anderson, the Chicago Public Health Department Deputy Commissioner and Chief of Operations for the COVID response, and Sandy Brown, Deputy Commissioner and Chief Racial Equity Officer for the Chicago Public Health Department. Christina and Sandy discuss the Protect Chicago Plus plan that works with community-based partners to reach and vaccinate 15 of the city's hardest hit neighborhoods. The City of Chicago's dynamic vaccination and partnership efforts have increased the percent of Black and Latinx Chicagoans who have received the first dose of vaccines from 18% to close to 59% as of the second week of March.
Can you tell us more about the Protect Chicago Plus plan and why it's such an important equity strategy to ensure COVID-19 vaccines are reaching the most impacted community members in your cities?
Before COVID, the Chicago Department of Public Health made a really explicit and really strategic shift several years ago to focus explicitly on health equity. We did a lot of work with our epidemiologists looking at life expectancy in Chicago, looking at the sociodemographic gaps in life expectancy across our different groups. And we did a lot of work understanding what was driving those disparities. And then COVID hit, right? And all of us got interrupted in the public health work that we were doing. And we knew very early on that this was not going to be a equal distribution of burden. And so from that moment in early April, the mayor's office convened a racial equity rapid response team. The idea was that we have very strong community-based organizations in Chicago that are well-developed, well-integrated in their communities, very highly trusted in an environment where there's no trust. And we brought all of those folks to the table and we said, what should we do? And we listened and we did what they asked, which is hard for a government and for a local health department that is in crisis. So then rolling into the vaccine, we've really been taking the lead from our community-based leaders, looking at the data closely. We're looking at a census tract level, actually, in a lot of cases, and mobilizing kind of door-to-door work within those communities.
The Racial Equity Rapid Response Team has been incredible in terms of the support and the diversity within that group, community organizations coming together with city leaders to talk about strategies across the board. And so we're talking about communication, outreach, what's the best way to get this messaging out, who is trusted within the communities. And so there was a real deep dive into the best approach and how we could meet these community members where they're at.
We were reading a bit about sort of the door-to-door approach, strike teams, if you will, and I think that's a very fascinating strategy. So I'm wondering if you could talk a bit more about that.
We worked with our community-based organizations. There were a couple that had some kind of workforce funding. And so we were able to pivot those folks into prevention strategies. We very quickly put together an RFP for a marketing firm that specializes in Black and Brown communications. So we have employees who help make sure that children have safe transit to school in the mornings. School wasn't in session, and so we took those folks and we sent them door to door, and we knocked on 400,000 doors in Chicago. We didn't have face-to-face conversations for COVID concerns, but we left a little bag with information and a phone number and references to our website. And so then when the vaccine was approved in December, the infrastructure was already there. We already had these partners that we were working with. And since then, we've been working to create a program where we can direct some of the new stimulus funding that we are receiving through the ELC grant and through the immunization grants to support this work, make it more robust, and kind of make it long-term. We've also set up activations in grocery stores and laundromats, places where people continue to have to go.
Tina, what has been sort of the response to this really boots on the ground approach? Like, have you seen kind of increase in vaccine uptake from certain neighborhoods? And also, what's been the receptiveness in terms of communicating about COVID and vaccines in, laundromats, grocery stores?
So we've been tracking this on a couple different levels. One is just looking at the race ethnicity of our first doses every week. Back in December, when we first launched vaccine and started vaccinating healthcare workers, only about 13% of the first doses were going to Black and brown Chicagoans. About a month ago, we had almost completely reversed that trend. 51% of Black and brown Chicagoans had received first doses in that week. Last week, it was 59%, which exactly matches Chicago's population. We're working with our city colleges to create a vaccine ambassador certification program where individuals who have received the vaccination and want to talk about it to their community members can go and take this kind of online course. That talks to them about what's the difference between an mRNA vaccine and these other vaccines. There's two kind of incentive structures there. The first is the course itself will be offered for free and can be used as continuing education credit at our community colleges, and so help folks kind of move towards completing their degree. The second piece is we're still trying to figure out the details on this, but we do want to make a very small incentive available to participate in the program.
Your data is showing that these approaches seem to be working. So I'm curious, are you using data strategically to direct resources in terms of are you looking at rates of vaccination and doing more door-to-door outreach or more activations? And then additionally, are you specifically allocating a certain percent of your doses to the disproportionately impacted areas?
Our EPIs are running this data every week, and we're reacting to it. We did this very nimbly and very quickly with testing in the beginning. And so we're kind of doing a similar thing with that. We learned a ton from testing that we're now applying to vaccination. We've had a bunch of community-based organizations that are getting together, volunteers, having like a crash course on how to talk to your neighbors about COVID and going out and knocking on doors. Our EPIs are equipping them with census tract maps that show at a census tract level what the case rate is and what the vaccination rate is. And so it allows them to prioritize pockets of their neighborhoods and have that visibility of like, where is their coverage and where is there not. And then I think because it's the community leaders and the service providers in that neighborhood who are looking at that map, they know what that map means, right? Like I look at that map and I'm like, I don't live here. I don't know what this neighborhood is. They'll say there's a creek that runs through the street and nobody will cross over it to get to this provider over here. So we need to put mobile sites on the other side of that creek, right? There's all kinds of stuff there. I mean, understanding cultural barriers and understanding where certain populations residency ends and begins and kind of where you need to switch languages. It's really powerful data in the hands of the community leaders. And so that guides a lot of it.
How are you incorporating populations that may not fall into these census tracts, but are still disproportionately impacted into your Protect Chicago Plus plan? So I'm thinking of folks who are incarcerated, folks who are experiencing homelessness. How do you incorporate strategies for reaching those folks as part of this priority vaccination push?
Those two specific populations have been in our forefront of our thinking from the very beginning. We had a really bad outbreak at Cook County Jail, which is one of the largest incarceration centers in our region. And we had a very rapid response there. We worked with some of our CDC deployment folks who are our top experts in infection prevention and in communicable disease spread, working really closely with our county partners Our Cook County Jail is a part of Cook County government, right? Not city government. And that's a lot of what we've had to navigate in this response, is interjurisdictional cooperation and communication, relying heavily on the relationships we've developed over the years across jurisdictions. But we had a very rapid response at Cook County Jail, and we've maintained that response throughout. We've worked with some of our large medical partners, Rush University Medical Center, University of Illinois at Chicago Health. At first, we were doing kind of rapid testing strike teams where we go into a congregate setting and do serial testing after an outbreak to make sure that kind of things were trending downwards. And now we've transitioned those and actually just executed some contract amendments to be able to do vaccination strike teams. Because now where there is an outbreak, we have a tool to stamp it out.
How do you see these efforts sort of extending beyond COVID, from a racial equity lens?
As you've heard, I mean, there's a lot of great work going on in this space, but we're also finding out sort of some pain points in the city in terms of our processes and our procedures and how we navigate even the RFP process. We're definitely seeing in many of these spaces where there's work to be done. And I think this is an excellent opportunity during COVID as we navigate through all of this. Some of it's testing out a new way of doing things. Now, is that necessarily going to be the way that we shift our work going forward? I think that remains to be seen, but I think that there's discussions that are to be had about this and that are ongoing right now with the mayor's office and with other city departments, including CDPH, to talk about what can we do to help support our Black and Brown communities as we navigate through this as a public health department. So I think for us as leaders of equity work, I think we have to continue to have these conversations and keep this on the forefront. And not lose sight of, what's happening here, but also how do we strategize and make changes, significant changes, whether it's, things that have been systemic or our policies and processes and procedures that have impacted our Black and Brown community negatively.